Hello everyone, I'm Dr. Tanupriya and I will be speaking about the sexually transmitted infections for NAC OSCE station. When you're outside the door, you have 2 minutes to read the question and make some notes. So let's take an example. An 18-year-old female comes to your clinic complaining of vaginal discharge for the last 10 days. In the next 8 minutes, take a focus history and there will be post and counter questions. For history taking, you need to remember this purple box right here. These are some pointers that you can use to jot down before you go in to take the history. When you're taking history, always ask for patient details, onset setting, course, frequency, and duration. What are the aggravating factors of their symptoms, relieving factors, associated factors, and alarm features? If the patient complains of any discharge, you need to ask for color, odor, consistency, amount, and blood associated with it, relation to sexual activity, and you need to take a complete sexual history. For female patients, you need to ask for the relation to menstruation and you need to take a menstrual history, gynec, and OB history along with it. PAM Hug Force is just a mnemonic that you can remember to complete your history taking. So, past history, allergies, medication, hospitalization, any urine symptoms, gastric symptoms, family history, occupation, sexual history, and social history, that is smoking, alcohol, and recreational drugs. The sexually transmitted infections, the most common symptoms that patients may come to you with will be urethral discharge, dysuria, that is pain or burning sensation on urinating. There can be some penile skin changes, itching, or any lesions. Male patients can often also come with any testicular pain or swelling and penile swelling. So you knock the door, enter, introduce yourself by saying something like, "Hi, I'm Dr. Dhanupriya. I'm the doctor on duty today. Can I confirm your name and age, please?" Also, to let you know that whatever we discuss here today is going to be confidential, so please feel free to share any concerns. You have to assure confidentiality right at the beginning due to the sensitive nature of the case. When you ask for concerns, like we discussed, you need to ask onset setting, course, frequency, and duration, co-copy for the discharge. Now, coming to associated symptoms, you need to ask for any local symptoms like redness, itching, any lesions like blisters, ulcers, or warts, any inguinal swelling, any pain with intercourse. Nearby symptoms are going to be divided by urinary tract and abdomen, so any difficulty on urination, any burning sensation, or any pain on urination, any changes in your urine that you've lately noticed. Abdomen symptoms can be abdominal pain, pelvic pain, nausea, vomiting, or any bowel movement changes. But remember, if they complain of pain, you need to take a history of when it started and OCD and PQRST. So, PQRST is the position of the pain, the quality of pain, if the pain is radiating, the severity on a scale of 1 to 10, and timing. Alarm features will be fever, night sweats, chills, any joint pain, swelling, skin rash, and weight loss. You need to take a complete sexual history. So, at what age did you start sexual activity? How many partners have you had in the past 12 months? Were they men or women? What type of sexual activity do you indulge in? Is it oral, vaginal, or anal? Do you practice safe sex, that is the use of condoms? Have you ever previously been diagnosed with a sexually transmitted infection? If yes, how long ago? Have you previously been screened for an STI? If yes, how long ago? Have you or your partners been diagnosed with STI previously? Or have you or your partner been involved in any high risk behavior like taking recreational drugs or via the injectable route? For female patients, don't forget to ask the menstrual history, the last menstrual period, any change from previous period, the frequency, duration, and regularity. You need to take a gynec history of if they've had any previous gynecological procedures like an IUD insertion. When was the last pap smear done? What was the result? If they've had an HPV vaccine taken before, and their obstetric history. So, if they have been pregnant before, did it result in live birth? If there were abortions, what was the length of gestation, route of delivery, and complications, if any? Your post encounter questions will usually look something like this. So, what are your differential diagnoses? What are the investigations you'd like to do? And what is your plan of management? Management usually includes both investigation and treatment. Let's talk about the differential diagnosis. Our most common differential diagnosis here is going to be chlamydia, gonorrhea, trichomoniasis. These are the top three that you might encounter, but you may also encounter patients with herpes simplex virus, human papilloma virus, and syphilis. When a patient comes to you with a vaginal discharge, you can also think of bacterial vaginosis or candidiasis, although they are not STIs, so you need to ask questions in your history to rule them out. Investigations that you need to keep in mind will be gram stain, gram culture, first catch urine, serology, and some special tests like pH paper test, whiff test, and pap smear for the female patients. For management, the first condition that we are going to discuss is going to be gonorrhea. So for gonorrhea, investigations will involve gram staining and culture. Treatment is going to be single dose of ceftriaxone 250 mg intramuscular injection plus azithromycin 1 gram orally to co-treat for chlamydia. Always remember, if you've not ruled out chlamydia, you have to co-treat because they often coexist. For pregnant patients, you can use the above regime, but in patients who are cephalosporic allergic, you can use gentamicin 240 mg of intramuscular injection plus a single 2 gram oral dose of azithromycin. Alternatively, you can choose to use cefixime, but that's not the best option. Remember, over here, you need to treat all their partners as well. Test of cure is usually not required unless the patient is still symptomatic despite the treatment, or if you doubt the compliance of the treatment, or if your patient is pregnant. For chlamydia, which is the most common bacterial STI in Canada, you need to remember the treatment will be with doxycycline 100 mg orally twice daily for 7 days, or you can give azithromycin 1 gram orally, single dose. Doxycycline is contraindicated in second and third trimesters of pregnancy. Here, the thing to remember is both chlamydia and gonorrhea are reportable diseases. You need to test and provide treatment to all sexual partners. All patients with chlamydia need to be tested and treated for gonorrhea as well. And test of cure is not routinely indicated but done 3 weeks after the completion of treatment when the compliance of treatment you think is suboptimal, if you used an alternate treatment regime, if the patient is still experiencing symptoms, or the patient is prepubertal or pregnant. Trichomoniasis, the discharge that the patient complains will be yellow, green, malodorous, diffuse, and frothy. The test here you can use is saline wet mount test and whiff test, which will be positive. You need to treat these patients even if they are asymptomatic with metronidazole 2 grams orally in single dose, or you can choose to give them as 500 mg orally twice a day for 7 days. But symptomatic pregnant women should be treated with the 2 gram metronidazole once. Trichomoniasis is not a reportable STI, but you need to treat the partner regardless of the symptoms. Coming to HPV, which is the most common viral STI in Canada. Over here, the clinical features will be wart-like lesion that the patient is going to complain. If it's a female patient, you can go for investigation with a pap test. Biopsy of the lesions can be done, and you can choose to determine the subtype of the HPV DNA using a nucleic acid probe, which is not routinely done. Treatment of the anogenital warts, patient administered will be podofilog 0.5% solution 2 times for 3 days in a row, then 4 days off, and then you will repeat this for 4 weeks. If it is provider administered, we have options like cryotherapy, trichloroacetic acid, surgical removal, and intraepithelial lesions. You need to also counsel the patient in this case, in case of HPV, for prevention with vaccinations and safe sex practices. Herpes simplex virus. This patient might come to you with clinical features of ulcerations with vesicles. And they also may complain of inguinal lymphadenopathy, that is lymph node swelling. Investigation will be by culture or PCR or a Zank smear. The treatment, if it's the first time that the patient comes to you with this, it's going to be acyclovir 200 mg orally 5 times daily for 7 to 10 days. If it's a recurrent episode, the dose is going to be increased to acyclovir 400 mg 3 times a day orally for 5 days. You need to educate the patient regarding the transmission, so avoid sexual contact from the onset till the lesions have completely cleared and use a barrier contraception. So here's the summary. Things to remember, points to remember will be physical examination for females will include pelvic examination, speculum examination, pap smear, swabs for culture and sensitivity, especially for chlamydia and gonorrhea, saline slide microscopy, and whiff test. Partners should be notified and should be treated. You need to give your patient advice regarding safe sex practices. Chlamydia and gonorrhea are reportable diseases. If you suspect your patient having high risk sexual behavior, you need to do screening for HIV and other STIs. You need to advise your patient, if it's a female patient, for pap smear regularly. You may advise your patient for vaccinations against HPV. And these are some hints you can remember for diagnosis. That most common are chlamydia and gonorrhea. If the patient comes with blisters, it can be HSV. If they come with warts, it can be HPV. Ulcers point you towards syphilis, and if it's a frothy yellow-green discharge, it points you towards trichomoniasis. Thank you so much for your time, and good luck with the exams.